Good evening, everybody, and welcome to our session here today. My name is Kavita Prabhu, and I'm from the Arab Association of Urology, and delighted to be with you here today. Can I request all our panelists to put your cameras on, please? Thank you very much. So again, we're delighted to share with you today a special edition that we're running just before our annual conference, calling it the Road to the 21st AAU Conference, the Road to Qatar. And this is something really special that we've been doing today. I'm going to take you through some housekeeping tips. So this webinar, for everybody's knowledge, is going to be recorded and it would be made available on the Arab Association of Urology website and on our learning platforms as well. All your participants will be muted by the organizer for better management of the session. We have a surprise at the very end of this webinar. We are giving away three free registrations to anybody who attends the webinar from the beginning to the end. So please stay with us. We'll do a draw at the end of the session, and you could be a lucky winner who would be coming and meeting with us in Qatar as well. Without further ado, it is my privilege and my honor to welcome today leadership that is present with us today, Professor Mohamad Moussa, who is the president of the Arab Association of Urology, Professor Yasser Farahat, who is the Secretary General of the Arab Association of Urology, and Dr. Khalid, who is the Deputy Chairman of the Urological Society of Qatar. Doctors, may I ask you to share your knowledge and welcome our guest here today. Professor Moussa, over to you.
So, good evening, everybody, dear friends and colleagues. First of all, I would like to welcome all of you to the road to Qatar, to Doha, Qatar, this evening. And I would like to thank my co-chairs, Professor Yasser Farahat and Dr. Khalid Al Rumaihi, for their efforts. Today, we will talk about advancement in robotic surgery, and we are having distinguished guests from the States, Dr. Vipul Patel, and from Saudi Arabia, Professor Raed Azhar, and from Qatar, Dr. Aboumarzouk. They will present their new things and new knowledge in the robotic surgery. Dr. Farhat.
Good evening, everyone. Actually, this webinar is really, as Kavita mentioned in the beginning, it's a special plan for having awareness of the annual conference. And this is the first year that AAU adapting this concept. And I think it will be a regular before our annual conference. We always be happy to let our delegates to be engaged with the conference as early as possible. It's a good opportunity that everyone could understand what we have in our conference in Qatar. And you will see some of our guest speakers today are, in addition to another 120 speakers, are attending to the Qatar. I'm just giving a briefing about the numbers that we are almost crossing 1,200 delegates expected to be attending in Qatar. We will be joined with World Video Urology and joined with Qatar Urological Society in outstanding venue that it is Itqan Center, that it's a specialized center. We didn't go for a hotel as usual in the conference, but we intended to have it in Itqan Center, which is outstanding simulation and the training center, where more than 12 or 14 workshops with hands-on training, starting from simulation, cadaver, wet lab, all kind of training and education will be available in addition to the plenary sessions and interactive sessions. So we kept the whole program contained in the training center to have the real life of training and education close to each other. Also, we are proud to receiving more than 580 abstracts from more than 75 countries all over the world. So we believe this is one of the biggest conferences that we have in the Middle East that you are invited to attend, and I believe everyone attend will enjoy. And whatever you're looking for, you will get it. Whatever the subspecialty, whatever the format of the education or training, you will find whatever you are interested in. In addition, the networking with the keynote speakers from all over the world, so you will get the opportunity to introduce yourself, to meet those experts and listen to their experience. I will not take too much. I will stop here, and I really appreciate the effort behind having this event happening today, and hopefully to meet all of you in Qatar very soon. Thank you.
Dr. Khalid?
Yeah, Assalamu alaikum wa rahmatullah. First of all, I'd like to thank Dr. Moussa and Dr. Yasser for organizing as such webinar as a road of AAU Congress in conjunction with World Congress of Endourology. I believe it's a very nice idea, and we could have it not only for the annual meeting, we could have it as collaboration between all other societies, because a lot of people maybe they cannot attend, but they will get benefit. Especially today, I am seeing a very eminent robotic surgeon like Professor Patel from USA, Dr. Raed from Saudi Arabia, and Professor Omar Aboumarzouk from Qatar. So inshallah, we will see most of you in our meeting after 3 weeks from now. And we are hoping to have a special version of Arab Association annual meeting. Thank you and welcome everybody.
Thank you so much, Dr. Moussa, Dr. Professor Farahat, and Dr. Khalid. That was a really good insight. And ladies and gentlemen, whoever's joined the call, indeed, this is going to be one of a kind, and you should have no regrets. So please do come and join us in Qatar in the coming weeks as well. Can I have the next slide, please? So again, it is an honor for me to put together the 3 moderators that we have today: Professor Moussa, who's the president, Professor Yasser, who's the secretary general, and Professor Saleh, who's the chief of surgery department and head of urology section HMC. It is our honor they will share with you their insights as well today. May I hand over to Professor Saleh, please? Professor, if you can please unmute yourself, Professor Saleh.
Yes,
Great.
thank you. Thank you very much, Kavita, for nice introduction. Thank you, everybody. Welcome everyone to this webinar, and welcome everyone in Qatar after 3 weeks. So no time, we'll go ahead with the program. Next slide, please. So the first topic will be presented by Professor Vipul Patel, who will talk about the new clinical robots in telesurgery. Professor Patel is a professor of urology, founder of the International Prostate Cancer Foundation, founding member of the Society of Robotic Surgery, board certified by the American Urological Association, medical director of the Global Robotics Institute, and medical director of the Advanced Health Cancer Institute Urologic Oncology Program. And we can talk till morning, but because of sake of the time, we shorten this introduction for Professor Patel because of the time. Professor Patel, please.
Yes, thank you everyone for allowing me to speak today. It's a fantastically organized event from what I see, and I do encourage the attendees to come to the meeting. It looks very robust. My job has been to help on the robotic aspect of the meeting, and I think it's going to be very interesting. And the reason I think it's very timely is because of the fact that I think with the new robots coming and the capabilities, I think you're going to see a large increase in the adoption of robotic surgery in the Middle East in the next few years. And so I think these topics will be more and more common. So let me go ahead and share my slides, if I can do that. Hopefully you can see my slides now. And let me see if I can
Yes, we
go-
can, doctor. Thank you.
Perfect. And let me see if I can go full screen here. Okay. So yeah, my discussion really is going to be about what's going on in robotic surgery and what are we going to speak about during the meeting. And we have many sessions, so we will obviously go more in depth. But these are the various things that we'll be talking about. New robotic platforms, I think, being a very important part. All of us know about the Da Vinci. There are many of them in the Middle East, but obviously compared to the rest of the world, the proportion is still lower. And partly that was economic and also training and education. And so those are going to be the two key topics: is what's changing and what's making the new interest there in the Middle East. I usually use the Da Vinci 5, but I think next month, or this month actually, I'll do my 19,000th robotic prostatectomy. So I've used all of these various versions. What excites me actually is some of the new things that are coming. The newer Da Vinci 5, I think ergonomically, it's very nice. The vision is very good. No AI yet, not too much analytics, but it's coming. And so the robots are getting more and more in-depth and complicated. But there are a lot of other platforms coming, whether they be multi-port, single-port, assistant robots, but they have a high bar. Obviously, we have a robot that works very well. It's been tested hundreds of thousands of times. And so these are some of the criteria. Definitely financially, these machines are going to have to be cheaper, but also the training and the education part is going to be important, especially in the Middle East, where we need better training. These are some of the systems that are out there. As you can see, there are a lot of them. These are currently available robotic systems. The ones in green and red, these are ones that are actually telesurgically capable, where you can operate remotely. And so that's going to be an important part of training and education, I think, in the Middle East, is being able to do it remotely. And so as you can see, in the US, there's a second system coming here. In many places, you already have the Medtronic Hugo. That's an important one. Microports to my system. I'm going to talk a little bit more about the cases we just did with that, but as you can see, looks very similar to a Da Vinci, and it works very similar. The Carina from Lenovo, we did part of their clinical trial in China, and as you can see also, this is more of a modular system. So a very diverse array of systems coming. This is a open console, and so I think you're going to get a chance to actually choose whether you have closed console, modular, multi-port, single port. All of these things are coming, and I see economically a little bit easier than we have had in robotics right now. I think the cheapest system out there is probably the SSI Mantra from India right now, a modular system. In the Japanese have also in Japan released the Hinatori. So this is just kind of a brief snapshot into what we're going to talk about. And the key is going to be these things. So it'll be part of our discussion in our course, talking about the functionality, the reliability, and then obviously the financial aspects. And then how do you train? How do you train enough surgeons to be able to actually use the platforms that you buy? And I think this is where telesurgery is going to really come into it. This has been my interest over the last few years, and we've been spending time in India, China, Japan, looking at these systems. And it is, I think, the time for telesurgery. For many years, 20 years since the Lindbergh operation, nobody really thought about telesurgery. But now you have better robots that are capable, and you have the telecom networks that are fast enough. And so this is why I think, why now? We have 5G, we have fiber, we have fantastic connectivity, and then you have cheaper robots. And so we tested the concept of, is telesurgery capable? And we went to China, we worked with our friends there, and we did various operations, many kilometers apart. This one was 1,500. We went as far as, 2,500 kilometers away, where my team was with the patient at a remote site, and I was in the operating room in Shanghai, but not in the operating room. I was in an office or in a conference hall, whereas my assistant was many kilometers away. And you can see here how we can monitor. And the issue of latency was actually solved in many ways. You have to make sure the signal can travel quickly enough that it's not perceptible. And here we have like 51 milliseconds, and we were able to successfully do a robotic prostatectomy. And I think this will have a role, I believe, in the Middle East, where remote training, remote education, and I think it's perfectly suited because your telecom networks are very robust. You have good regulatory agencies, and you have probably favorable government regulations. How far is too far? You know, we have machines. We have MedBot here in Orlando. And this year, actually, to Arab Health, we actually connected, and I was actually manipulating the robot at Arab Health, sitting here in Orlando in January. We've gone as far as 13,000 kilometers away, 26,000 kilometers round trip between Orlando and Shanghai. Obviously, the latency is more significant. It's over 200 milliseconds, so that needs work. But we are able to control these instruments pretty well. And so I think the era of telesurgery is going to be very important in terms of training and education. And I think that the closer distances are much more reasonable. And currently from Orlando, we're connected to Shanghai. We are connected to Africa, and we're also connected to Brazil. And we're still in the process. We're not doing clinicals yet. But the benefit is, look, think about the humanitarian potential. Instead of patients having to travel, surgeons having to travel, this has a huge humanitarian effect. And that's really been my interest, is the humanitarian aspect of telesurgery, reducing geographic disparities and economic boundaries. And so we formed a humanitarian foundation that is working with many health organizations. And my team and I just went to Africa, to Angola, and we were doing telesurgery there remotely. And our goal is, over the long term, is to be able to proctor and train them remotely from here. And we connected yesterday, and we were able to actually maneuver the robot from here to Angola with latency that was not perceptible. So I think all of this is very important. I'm here today because I'm really excited about the MOU we just signed with the Arab Association and the Society of Robotic Surgery. You know, I founded the society, and I'm the executive director. And we reached out to our friends in the Arab Association and said, look, we'd love to just partner with you on your meeting and then have you guys come to our meeting. And I think this is going to work out very well, because we can add the aspect of robotic surgery. The other aspect we can add is we're training a lot of your guys, and we've seen a huge interest from the Middle East in terms of training and education. And I think 50% of our applicants last year for my fellowship were from the Middle East. And as you see, you have three guys, the two on the end and the one in the middle, one from Egypt, one from Qatar/Jordan, and one from Lebanon. And these are extremely talented guys academically and robotically, and they'll be coming back to you. So you have the next generation that we're training and sending back to you. So we're excited to work with these guys. They're fantastic, and they're going to be with me at the meeting, so you'll get to meet them. Our Congress is going to be next July, 2025. We think there'll be 50 different types of robotic systems and 85 companies, and well over 2,000 registrants. And it's a multi-specialty, very exciting meeting. And as part of our collaboration, the society is going to offer a 50% discount to any member of your association that wants to go to our meeting. And they just have to use the QR code or talk to your administrative faculty, and we can arrange that. So we really just want you to come and attend and be part of us. And I'm really excited about coming because I enjoy Doha and I enjoy seeing my friends. So happy to take a few questions, but I just wanted to tell you what's in store. Thank you so much.
Professor Mohsen, if you
Thank you very much, Professor Patel. I think we will leave the question till the end of the three presentation. So we will go ahead for next presentation. No, the one before. One before, please. Dr. Raed. Yes. I'd like to present Dr. Raed Azhar from Kingdom of Saudi Arabia, who will be talking about robotic upper urinary tract reconstruction. What is the new in that field? Dr. Raed, he's Professor of Urology at King Abdulaziz University, Jeddah, Saudi Arabia, President of Saudi Urological Association, President-elect Arab Association of Urology, founder and director of the first private robotic program in Saudi Arabia. Welcome, Dr. Raed, and present your talk, please. Thank you.
Okay, perfect. Can you see my screen?
Yes, we can, Dr. Raed.
Okay, perfect. First of all, I would like to thank the organizing committee, thank all of my brothers and friends and colleagues in Qatar for hosting this exciting event. And I'll be very happy to meet many of our friends and colleagues very soon in Doha. So I was asked to present about robotic surgery for upper urinary tract reconstruction, what's new? I have nothing to disclose. So the outline of this talk will include principles of upper urinary tract reconstruction, what are the different preoperative evaluations that we need to do, an algorithm for proximal upper urinary tract reconstruction. I'll be focusing mainly on buccal graft urethroplasty and what about our experience in King Abdulaziz University Hospital. So what are the principles of robotic upper tract reconstruction? There's no doubt that robots allowed better magnification, excellent precise suturing techniques, allowing to have a watertight anastomosis. There are different adjuncts like the ICG imaging that can allow to have and maintain well-vascularized tissue. Always I leave a stent and drain. I always try to use an omentum to wrap the anastomosis. And always you have to be flexible in these cases. You have to have the consent open because you never know what you're going to see inside the abdomen of the patient. This slide that you may see in different talks when they talk about robotic reconstruction options for upper urinary tract, it is a very nice slide because it shows you the different procedures that you can do according to where is the structure. So if it is in the upper third, mid third, or lower third. So if you see, when you focus on the upper third, the primary procedure will be pyeloplasty, for example, and then you have different adjunct procedure that you may consider, like renal pelvis flap, downward nephropexy, buccal mucosa, a mental wrap, and so on for the mid third and lower third. Preoperative evaluation, it is really important to have an extensive understanding of the patient anatomy. So there's no doubt that you have to have an excellent cross-sectional imaging, excellent antegrade and retrograde pyelograms, nuclear medicine scan to assess the split function of the kidney. And this is an important thing, which is I always like to leave the ureter unstented for a period of time. Usually 2 to 4 weeks. So if the patient has a double J stent, I always like to remove it. If the patient cannot tolerate that, I always prefer to put a nephrostomy tube. Preoperative urine culture and specific antibiotics are important. And the consent, I always leave it vague and open to different options because you may end up in some cases in the extreme case of auto-transplantation. So you have to have a wide range of options that you can put on the consent, and of course, you discuss that with the patient. The robot allowed the use of the ICG, either intravenously or through the ureter, and this has different advantages to identify the structure, to identify the vascularity of the tissue. And also, I use many of these cases, I use flexible ureteroscopes that can allow me to find the structure, calibrate it, and test the anastomosis. This is a very nice algorithm for proximal ureter reconstruction. So first of all, you need to identify the location. Where will the kidney or bladder reach? Can you perform pyeloplasty, ureteral colostomy, or Babari? Is it a short structure, like 1 to 2 centimeters, where you can do primary anastomosis? Or is it a long structure with a small lumen? Is it 2 to 10 centimeters that at this point you need to do like only flaps, like buccal mucosal grafts? Or is it a long, 2 to 10 centimeter short area without lumen, 1 to 3 centimeter. At this point, you need to do augmented anastomotic strictures. I'm going to show you some examples. Or if it is really a long area without lumen, and this is you're left out with no option other than to do the ileal ureter replacement. And if all of the above failed, you may need to do auto transplantation. So buccal mucosa graft, which is I'm going to focus because of the sake of time, it's a very large topic. I cannot finish it in 10 minutes. But buccal mucosa graft, was described in 1941 for urethroplasty by Humby, and now it is considered the gold standard for urethroplasty. It is an ideal urethral substitute. It is easy to harvest, easy handling characteristics. It had an early ingrowth and graft survival. And this concept has been adopted or was adopted in urethroplasty in the 1990s. This was done by in a baboon live survival model by Johan Nodé from South Africa, and he did the first human series of 4 patients in 1999. Until 2013, the adoption of robotic to use buccal mucosa graft was not done until Dr. Li Zhao from NYU, who did a first robotic series of 4 patients with a median follow-up of 15.5 months with a 100 success rate. So you think about it, if you have a structure and you want to do ureterostomy, for example, in the mid or proximal ureter, it is not actually a 2 centimeter structure. It is actually a 4 centimeter gap, because remember, you need to do spatulation anteriorly and posteriorly. So this 2 centimeter, it will end up with a 4 centimeter gap. So this is the idea behind buccal mucosa uteroplasty, is that you will maintain the link while augmenting it with the buccal mucosa. It is very important to distinguish. Do you have a narrow segment where you need to do just an only ureteroplasty, so you're leaving the posterior wall as is, and you're just opening the ureter anteriorly and laying a buccal mucosa? Or is it an obliterated segment where you have you need to cut the ureter and you need to do back wall repair, and then you need to apply the buccal mucosa on top at the anterior wall. So this is the first multi-institutional experience with robotic buccal mucosa graft that was done in a collaboration between mainly 3 surgeons, Dr. Li Zhao, Dr. Michael Staffelman, and Dr. Dan Yun. And they did the first series, they did 54 patients, and they had an excellent success rate of 87%. This series was updated and was presented in the last AUA in San Antonio, when they updated the series to 163 patients over 10 years between 2013 to November 2023, with a success rate of 91%. What about our experience at King Abdulaziz University? So since May 2023, we did a total of 7 cases with very good results. The results will be published soon. The story of this is when I visited Temple University as a visiting professor, I got to know Dr. Dan Yun closely in the OR, and in collaboration with my colleague and friend, Dr. Ihab Said, who's a reconstructive urologist, who does mainly urethral reconstruction, but he helped me a lot in harvesting the graft, and also giving his insights and tips and tricks when he does the urethroplasty to be applied to the ureter. Let me give you some cases. So this is the first case. This is a 34-year-old male patient with a recurrent stone former. He underwent 3 ureteroscopies. He developed stricture. He was treated with laser and balloon dilatations 2 times. So as you can see from the picture, he has a narrow stricture, but it is non-obliterated. So as per the algorithm that we discussed before, so this is a long stricture with a small lumen between 2 to 10 centimeters. So we used an onlay buccal mucosa graft. So this is a video of the actual surgery. So this is, you can see the flexible ureteroscope. We use the infrared imaging, the Firefly of the robot to identify where exactly the structure is according to the light that we saw. And now we are opening at the structure. You see the light of the flexible ureteroscope inside. And then once we were able to cut that structure part of the ureter, you will see that the ureteroscope passed all the way up just to make sure there is no other structure upward. And of course, there are no stones or something that we need to remove. And then we measure the structure length. As you can see, this is about 2.5 centimeter. And then we brought the graft in. This is the buccal graft in a piece of glove. And then we started suturing the an only buccal mucosa on the ureter. And this is just to trim the buccal graft. You try as much as possible to have an exact size of the graft. You don't have it too much redundant. And then you just do and spend time to do a watertight, tension-free suturing to have a nice result. And as you can see here that we are suturing, the beauty of this, you don't need to dissect, you don't need to skeletonize the ureter and deprive the ureter from its vasculature from behind. We just lift the ureter as is, we just open the anterior wall, and then of course at the end, we'll apply an omental wrap to help and secure the graft. This was actually the first case we did. And this guy, he's now almost, so since May 2023 until now, he's been following up with excellent outcome. This is another case, a 28-year-old gentleman, right single kidney. He underwent left nephrectomy and chemotherapy at the age of 6 due to Wilms tumor. He had a history of appendectomy. You can see all the scars in the slide. In his abdomen, he has a recurrent stone former. He underwent 4 flexible ureteroscopies and stents. He underwent 1 endoscopic management of uterus structure with laser and balloon dilatation. He had 2 PCNLs. He lives with percutaneous nephrostomy tubes for the last almost 1 year. So this is the picture. This is the slide showing there is a stone in the kidney, and there is, as you can see, dead end. So this is the ureter completely obliterated at the end. There is no connection with the distal ureter. This is the antegrade and retrograde pyelogram showing there is no connection. And this is the ureteroscopy. And as you can see in the picture here in the X-ray and also in the video, that we reached a dead end where you cannot actually connect the 2 ureters. So this is as per the algorithm that we mentioned before. This is a long structure of 2 to 10 centimeter with a short area without lumen of 1 to 3 centimeter. So we did an augmented anastomotic buccal graft ureteroplasty. We have the video, but because of the sake of time, I just chose this picture to show you. In conclusion, so management of complex ureteral structures required thorough understanding of both structure and patient characteristics. Multiple options should be considered for each patient. Buccal mucosa graft is a good option in select patient, and it offers versatility, promising outcomes with minimal morbidity. If you really need to learn about these techniques, I really highly recommend this book of techniques of robotic upper tract reconstruction, written by Dr. Stifel Manzau and Dan Yoon and Chester Koh. Again, I'll be very happy to see everyone in Qatar and looking forward to that. Thank you very much.
Thank you very much, Professor Raed, for this comprehensive talk about the reconstruction in the upper tract. We'll leave the question to the end. We'll move further. Can you please show me the next slide? So we are going to present the third speaker, who is Professor Omar Aboumarzouk, who will present about the robotic surgery in Qatar, what is the current state and the future program.
Doctor, while he's setting up his slides, I'm going to tell all the audience, feel free to put in your questions in the chat box. We will take the questions at the very end. The chat box is open for you to type in your questions. Thank you. Go ahead, Professor Omar.
So Professor Omar Aboumarzouk, he is the Professor of Clinical Urology in Qatar University. He is the robotic surgeon in Mohamad Medical Corporation. He is the chairman of the Clinical Advancement Department in Mohamad Medical Corporation and the vice chairman of Surgery Department for Research. And he is the director of Clinical and Applied Health Research in Qatar University. He has a lot of books and a lot of publications We cannot mention them because of the sake of the time. He was an added value to Hamad Medical Corporation when he joined us. Please, Professor Omar.
Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakallah khair, Professor Murshid. Firstly, I'd like to welcome everybody to the webinar, and I'm looking forward to meeting all of you during the conference. Okay, so to give you an overview, robotic surgery is the future. Okay, as someone who's trained in open and laparoscopic surgery, the advantages of robotic surgery are significant. The improvements in accuracy and efficiency, especially in complex reconstructive surgical procedures, is multiple times been published. And if you've never seen an operation and you're normally doing it as an open procedure and you see it for the first time done robotically, you'll be astounded at how actually the procedure looks much more simpler. In the MENA region, this has slowly been embraced, and this surgical technological advantage has been utilized in multiple centers. The benefits of robotic surgery is enhanced precision. Of course, you could see the magnification of the robot significantly more than open or laparoscopic procedure, minimizes damage to the tissue around it. It is a minimally invasive approach, so the advantages for the patient are significant. And it's been documented that it reduces complications significantly. A surgical outcome is as well been documented to be that surpasses open surgery. And that's one of the goals of minimally invasive surgeries, to overtake open surgery in most procedures. And I would probably say that the majority of surgical procedures done here at Hamad Medical Corporation Urology has transferred from an open to minimally invasive / robotic surgery. It does reduce the recovery time and enhances patient experience, where with open surgery, the patient can stay on the ward for up to a week, maybe longer, depending on the procedure. The majority of patients done robotically are in the hospital for 1 to 2 days, maximum 3 days, with significantly reduced pain and early mobilization and rehabilitation. Now, global trends across the world, if you could quickly just have a quick guess of how many procedures were done in 2023 on the Da Vinci, there's 4 options here, but for the sake of time, we won't lie. In 2023, there's been over 2 million procedures done robotically, whereas overall, the trend is about 14 million. And these are over 9,000 systems worldwide. And only in 2023, about 1,600 were placed. Worldwide, the procedure trend is on the rise, and urology being the head of technological advances, it is the most utilized specialty to take advantage of this modern technology. In urology, prostatectomy is the #1 procedure conducted, but across multiple specialties. There also you can see gynecology, general surgery, and colorectal surgery, as well as hernial repairs. Are also high numbers utilized. Here in HMC, this is the global trend across urology, gynecology, cardiothoracic surgery. And we're proud to say that we're doing the majority of which from a urological perspective, and we've adopted partial programs to enhance donor nephrectomy, cystectomy, to include into our armament of robotic procedures as well. Similar to our colleagues in other types of surgery as well, they're slowly increasing their procedures, which is what they do. Same thing for hernia repair, upper GI, colorectal surgery, bariatrics, and hepatic surgery. Overall, since 2020, 2021, where we were around 200, 350 cases, we've now doubled the number of procedures we do across the board, and we're expected to hit about 600 by the end of this year. Urologically, we're about between 150 to 200 cases. Again, we're expected to hit about 200 cases urologically. Gynecology is the same trend, as well as general surgery and bariatric and liver surgery. In short, the majority of everybody who starts using utilizations of the robot do find it significantly more better than their standard practices and have adopted it one way or another. Our cardiothoracic colleagues have increased slowly over the years in adopting more and more surgeries. And though this is a urological conference, but this is something that was interesting that it's across the board. Everybody who puts their hands on the robot and learns how to use it will find it significantly better than their standard practice. So we have 5 systems that are utilized in hospitals, and the most recent one is in Aisha bint Atiyah Hospital. But in Hamad General Hospital, we've nearly done 2,000 robots since 2008. Milestones that we've achieved here in HMC is the first mitral valve replacement, and that was done completely robotically by our cardiothoracic team. And our first robotic recipient kidney transplant was done at Hamad not so long ago as well. This is Aisha bint Atiyah's hospital, which was opened nearly a year and a half ago. And since its inception, in the first 6 to 7 months of its operating, we've done over 100 procedures, robotic procedures. And it's slowly gaining momentum that every specialty in this hospital is utilizing the robot, where we're actually using it 5 days a week. Now, perceptions of robotic across the MENA region. This is a lovely 2 papers done by our colleagues. The majority of surgeons do have a positive outlook on robotic surgery, and these are amongst trained, skilled professionals. However, they did have concerns about training the next generation, as well as cost and infrastructure and limited awareness across multiple specialties. We still need to convince a lot of our colleagues that this is the way to go. They also did, for this paper, looked at the robotic perception from a patient point of view, and surprisingly, they did find that there's limited awareness. There are cost concerns and skepticism and trust. As with most new technological advances and new procedures, patients tend to be skeptical about conducting something that's only new and just started, despite the evidence suggesting it might be better. So it does take time for convincing the patient himself. Challenges in robotic, number 1, as Dr. Patel mentioned, the training requirements. It does need quite a bit of advanced training, and it does give the resident or the fellow a bit of disheartening when his trainers and mentors are then themselves on their learning curve. However, a lot of centers have now surpassed surgical learning curves and are able to provide this training to the next generation. Cost implication remains a high cost of call for concerns across multiple hospitals. However, the evidence suggests the more procedures you do, the eventuality is that you will become cost neutral. And multiple studies have shown that the cost, though the surgical cost of a procedure might be high, the benefits of readmission and complications and so on that come in addition to procedures are significantly less, which outfits the general cost of the robot. And of course, infrastructure. Most hospitals are not built to have a robotic dedicated theater. So when we were establishing Aisha bint Atiyah Hospital, we bared that in mind that we're going to have a dedicated robotic theater. So recommendations for growth across the region is that there should be a structured training program specifically aimed at robotic surgery. And I'm proud to say that at HMC, we do have a robotic training program led by Dr. Abdullah Ansari and Dr. Khalid Al Rumaihi, where our robotic fellow or robotic oncological fellow is on the verge of becoming independent in most major procedures, and hopefully by the end of his fellowship, he will significantly add benefit to the program. Fellowship opportunities, in our opinion, should extend beyond just one country and should extend beyond multiple regions to utilize the skills available from different countries from their specialists. Awareness campaigns is extremely important. I think not only for colleagues in urology, but in other subspecialties, as well as patient awareness, that there is a robotic option, that it is significantly better, and the evidence has suggested that as well. And again, mentioning the cross-border research and skills collaboration. One of the best forms of training is that across the region, robotic fellows collaborate with each other and join each other's surgical procedures to gain more benefit across the board. Next slide, please. So in conclusion, adoption growth is something that is positively trending through to modernize surgical practices across the board. However, till now, across the Middle East, only 1% of the world's installed robots are here. Hopefully, with all the new technologies that are available, this hopefully will increase the trend that we'll have more robotic procedures conducted as more systems are being installed in the Middle East. Training gaps can be easily rectified by structured robotic surgical training in a centralized manner in our region, rather than hospital to hospital basis, but across a centralized focus group. And of course, public awareness and future outlook are extremely important for the regional growth for robotic surgery. And thank you very much, and looking forward to seeing all of you in the upcoming conference.
Thank you very much, Professor Omar, for the useful talk and comprehensive experience.
Thank you, Dr. Morshid, as well, for anchoring the session for us here today. Can I please ask our speakers to please put your cameras on, and may I request Dr. Yasser Farahat to lead the Q&A session for us here today. We have some very interesting questions in the chat box, so Dr. Yasser will facilitate these conversations. Dr. Yasser?
I appreciate topics. Many interesting questions are there, but I'd like to start with Dr. Raed Azhar about the buccal mucosal graft. Many questions about that. If you are happy to mention all of them. The first one is about the lower third ureter. Is it an option, or other like SOSH or Boari flap could be the option? This is one. The second one about the who are planning to do robotic buccal mucosal graft for urethral stricture should be familiar with reconstructive surgery as open surgery. That this could help or facilitate his practice, or his learning curve will be better. These are the two questions. If you can give brief answer for these two, please.
Okay, for the first one, which is can be used for lower third, yes, it can be. But in general, lower third, you have options. Like you have better options actually, like SOSH, reimplantation of the ureter. We have Boari flaps, so you have better options than the buccal graft. But let me tell you something. I had one patient I did recently. She had radiation to the pelvis. She had really frozen pelvis, very small bladder capacity. And the vascularity of the ureter was like, I didn't want to really play with like taking the ureter and then reimplanting it again in this small bladder. She had a stricture. So I decided to do a buccal graft while leaving the ureter intact where it is, because it was literally a frozen pelvis. And actually she did well. This was done 4 months ago. Until now, she's okay. But it's not that, you know, not as used as in the proximal and mid-ureter. The second question, which is about, do you need to be a reconstructive surgeon to do buccal mucosal? I think you need to know the principles. You need to do, you know, the principles of reconstruction in general. It's a technique. Once you are familiar with the robot, you have the luxury of having multiple adjuncts that you can use with the robot to help facilitate all of this. And always it's very helpful to have, and actually I'm lucky to have a colleague who is with me in these cases, because it really saves time. Because one of the questions also that came up, which is, do you measure, do you do like the harvest the graft and then you do this, the buccal graft while you do, like, what is the order of that? What actually we are doing, we do nasal intubation. we put a patient in a certain way in the OR, in his face. So while I'm doing the graft, and then while I'm doing specifically harvesting the omentum or bringing the omentum towards the graft area, I already gave Dr. Ihab the specific length of the graft that I want. So he is working on harvesting the graft, and then I insert the graft after, so we work together at the same time.
So you are doing like a teamwork for saving the time and getting the best outcome. Last question about the buccal mucosal graft, asking about the long term. I think you started just a few years back, but what about the long term?
Yeah. So the longest study that we have, or the largest study that we have, which was like the multi-institutional study, it was like 163 patients over 10 years period. So their median follow-up was 40 months, and their success rate was 91%. So they have success rate. Still, it's a case series. You have to understand this is more of a before the last resort option. It's not like the last resort. It's a before the last resort, because if this fails, the good thing about it is you can do ileal interposition, you can do autotransplantation, you can do other more major surgery after that. So it's not like the end of options. But so far, although the length of follow-up is not that much, like we just started, as I said, in May 2023, and this is like the oldest patient that I have. Still, the results are excellent so far. I didn't have to go again and to repeat any of these procedures so far in all of these 7 patients that I did.
Last question. Questions are very interesting. Asking about the using alternative than the buccal mucosa, like Gore-Tex. I think there are multiple material. Do you have experience about difference between buccal mucosa and the others?
I don't have experience. I have only with the buccal graft, but we know that other like peritoneal flaps can be used. Gore-Tex, I think maybe the stones formation in the ureter maybe preclude doing that in the ureter. But I think buccal graft are really an easy thing to do, harvest with a very limited morbidity.
Do you think having a buccal mucosa tube, not graft, could work in ureter?
I don't think so. You have to have a back wall from a ureter, but to have a tube, because you still have this, you have to have some kind of you need to the graft to be taken by the host area. So not having at all any vascularity in that area, I don't think it's gonna work.
Okay, Dr. Patel, are you still with us? Dr. Vipul Patel is here.
Sorry, Dr. Farhad, hi, how are you? I'm Shadi Sayedi. I'm a fellow with Dr. Patel. Sorry, I had to run to surgery, but he placed me in his place to answer any questions if you have any.
Yeah. Actually, the main question about the telerobotic surgery, how safe and what is the ethical and regulatory issues behind the telerobotic surgery. This is one point. And the second one, the value of training remotely through telemedicine. Is it the same as in-person training with hands-on? Do you have any comment about these 2 points?
So yes, just to answer the first question. So telerobotic surgery in general, it's the value, the ethical part. Just to answer the first part, the ethical part is still up in the air. There's a lot of discussions, especially within the US and obviously internationally, as to was it ethical because of the patient-surgeon relationship, since that was basically almost non-existent, or is it who is the responsibility on if there are complications? These are things that you don't have to worry about when there's in-person surgery as compared to telerobotic surgery. So these ethical implications are still in discussion, and Dr. Patel actually started a working group, a collaborative community, for telesurgery. It's over 120 robotic surgeons and companies and regulators and people from WHO. And we basically are trying to come up with guidelines as to what is the best and effective and safe way to conduct telesurgery in general, without harming the patient or affecting patient autonomy. So there's still no defined guideline yet. We have published papers on this as what we think is the right way to go. There's one paper Dr. Patel published called the 10 Commandments of Telesurgery recently in the European Journal. That discusses a lot of the do not do's for telesurgery, and that really touches upon the ethical part. To answer your second question, which is what is the benefit of telesurgery in terms of versus live training and as opposed to virtual training? And when it comes to virtual training, there's a sense of giving the surgeon, the trainee surgeon, a bit more autonomy, because because he knows that even though the other surgeon is he's there virtually, as opposed to being right next to him and can take over. So the safety net is still there. However, it's not as secure, which gives the surgeon that's performing the surgery, not the trainer, however, the trainee, a bit more autonomy and freedom of movement. And they're able to rely on themselves and become more independent. And usually we think that we're going to reserve these type of trainings where it's virtual telesurgical trainings for robotic surgeons that have started their career and are trying to do more advanced cases, not the basic ones. And this is where the expert comes in and is there when when the other surgeon starts hitting roadblocks and needs a bit of help, as opposed to doing the full surgery remotely.
So I just want to move to Dr. Omar. There are some comments about the training program that you are adapting in Qatar, and also Dr. Raed in Saudi. So what are the challenges of adapting? I know it's many, but if you can brief, what are the challenges of establishing such robotic training program for robotic surgery? Dr. Omar.
I think one of the first one is fellow selection, because this is a new technology and everybody's very keen on jumping on board. But if you're going to be training, say, for example, we have 7, 8 residents, and then we have another 3 or 4 fellows in different subspecialties. They all want to train in the robotic scheme. So we have to case select which fellow is the best to actually train to get the full benefit from robotic surgery, that he comes out of it as a skilled surgeon or a surgeon that could independently operate and eventually reach his learning curve. So in Qatar, we do have a robotic simulator, a functioning system in Itqan. I think the video that was presented in the beginning has shown it. And all our residents are required to do various scenarios and reach a score of 85% on the simulating robotic procedures before they're allowed to come into the OR and assist as a bedside surgeon. Now, the scheme that we put in place so far has been successful with our fellow. He's, mashallah, he's becoming more and more independent with more and more time. And it's about caseload. So you have to case select that he's going to be reproducing the cases and the skills that he learned over and over and over. So if he participates in surgeries on a regular basis, rather than jumping around from one type of surgery to the next, that significantly enhances his training. To put a training scheme into place itself is not difficult. It just needs participation and agreements between various centers and various hospitals and so on. And then just do it in a structured manner that the trainee could reach the very basics of their learning curve early on. And again, using the simulator, putting in 100 hours on the simulator, by the time he hits the patient side, he's already very knowledgeable in how the robotic procedure works in various aspects of it. And that's how we overcame, for example, a small number of patients in a specific procedure.
I will close last question to Dr. Shadi, if you can, because we are out of time. You know, many surgical robots are coming in the market. How does some hospitals in our region can adapt which robot than the other. Dr. Patel came back. So the question about the many robots coming to the market nowadays, and for our region, each organization or each hospital, how to choose, how to select, how to compare between them.
Yeah, I think we can help there. I think the best is you have to try them. So I've gone around the last few years trying all of them. And so I think many of them are actually very good. There's the Chinese ones, the Indian, and the Japanese. And I think first is going to be cost is going to be important. When you have systems that are comparable, and they are now, I think, then you have to look at cost. You have to look at support. Like, it's not good enough just to buy the robot. The company has to be around and support you as well. And then what's their plan for training and education? Just buying a robot. We found this in Angola, in Africa. We were just there. They didn't just buy the robot. They bought a whole program for training and education that basically guaranteed that their people would be trained and it would be done safely, and that the patients would not be affected too much by the learning curve. So I think it's not just about a machine anymore. It's about what kind of support will we get, and can you train our surgeons to use it? Because the machines are good and they're cheaper. And I've been very impressed with ones, and I know many of these machines are going to be there at the Congress, and when we have our meeting, we usually have 40, 50 different type of robots for different specialties. There's not only 10, there's like 40, 50 different robotic systems these days.
Yeah. We'll come to a very important point. We need your feedback. If you wanted to send a fellow to your center to have a training, and if you will adapt tele-robotic training while he is sitting in his home country, what is the learning curve difference between both?
Yeah, I think the reason telesurgery is going to be important is it opens up training to more people. Right now, robotics is more for the wealthier countries and for the ones where they have trained doctors. Remotely, you can have training for a surgeon instead of having 3 proctored cases, which is what some of the requirements are, is that they just have to be trained 3 times. You can have 20 because the surgeon is at their home institution. I think this will level the playing field in terms of robotics, where a surgeon, the hospital can say, look, we want you proctored for 20 cases, and the surgeon doesn't have to fly there to train them. They will obviously have to go to the surgeon for some training, but especially like countries in the Middle East, ones that we just worked with in Africa, the fact that I can connect to them from Orlando and help them if they get in trouble, it's huge. For patient complications, the humanitarian implications are vast. And so I think that's where telesurgery is really going to help. And that's why it's great that you're having this Congress. I think the attendees will get a lot of reward out of coming to your meeting.
So you believe that robotic training will reduce the cost, reduce the logistics behind the travel, and it can improve helping the learning curve of the surgeons, and it will come at the end with the safety of the patient by mentoring from remotely for some cases.
Yeah, exactly. I think it's going to allow more surgeons to be trained. It's definitely going to reduce patient complications. If they get in trouble, somebody can take over. Just overall, I think the whole landscape of robotic surgery will change. But telesurgery, I'll talk about it. There's a lot of challenges still ahead. The regulatory, the legal, the credentialing, and that I'll go over in my lecture when I'm there.
Okay. Actually, we are exceeding the time limit, so I'd like to thank all of you for your time and your interesting topics. I will keep the last part of our webinar today for announcement of the 3 winners attended with us today to have a registration to the AAU annual conference in Qatar next month. Kavita, do you have the draw?
Yeah. Can we have the next slide? Yes, doctor, we do. Can we have the next slide? Thank you again for joining us on this session. We have a draw. We've drawn it from the people who have attended here with us here today. And the winners are, Doctor, you can announce them. These are the 3 winners for pre-registration to the conference. Doctor?
So the first one, Dr. Linda Shamma from Lebanon. Congratulations, Dr. Linda. And Dr. Samir Matar from Iraq. El Sikali from Saudi Arabia. It's a great
Dr.
honor
Saikali
to
is
have all of you
my fellow's
attending.
father.
Dr. Wael Saikalis.
Yeah, he's my fellow Shadi's father. So look, Shadi's very excited that his father's coming.
Oh,
His father's a urologist in Saudi, and now he's gonna get to see his son in Qatar. So this is very nice. Thank you.
Okay. That's
So-
a great opportunity.
thank you again, everybody, and
Kavita, go
thank you to the panelists. Thank you, panelists, and thank you. Thank you to all the panelists for being here today, for the subject matter experts. We truly appreciate your knowledge and wisdom here today. We're going to give one more try to the conference video that we had. Couple, can we?
For the video, Dr. Moussa, can you just closing remarks from
Sure.
your side, please?
Yes, I would like to thank you all. It was a very interesting session. We have got a lot of information about robotics, and maybe you will have more informations if you will attend our annual conference in Doha, in Qatar. I'm happy to see you all over there, and have a nice evening today.
Dr. Khalid, do you want to say something about the hospitality and the lovely city of Qatar, in addition to the scientific program, to encourage our members to attend?
Well, I cannot talk about my home country, but I encourage everybody to come. Inshallah, we will have a good time, and they are welcome. They will be our guests, and hope they will enjoy. And as I said, I am happy with the arrangement happened so far, with the professionality of Arab Association in collaboration with World Congress for Video Urology. So we are looking for an amazing version of conference. So everybody, I encourage them to come, and they are most welcome, inshallah.
Thank you. Kavita?
Thank you, doctors. Thank you very much. We're going to give one more try to the video, fingers crossed. And thank you again for being here, and good night. Couple. No, couple, it's still not playing with the video. I mean, the sound. Okay, something came now. Yes. Thank you, everybody, and good night. Thank you for being with us here today.
Great.
Bye-bye.
Thank you very much for
Thank
the
you.
nice organization. Thank you very much.
Thank you, Doctor.